Should I start or Dr. Jimit? We should wait for Jimit. Jimit had come. Yes, Jimit.
So good afternoon, everyone. We welcome you to second day of the Diabicon Diabetes Virtual Congress 2020. We had a wonderful session in the morning, and now we are starting with another session with the international speaker, specifically Cody Sympodia. And for that, we would like to invite our chairpersons for this prestigious session. So first of all, I would like to invite Dr. V.N. Shah, our own Dr. V.N. Shah from Ahmedabad. And also I would like to invite Dr. Ashish Dengra, diabetologist from the Jabalpur city. So I invite both of them to continue the proceedings for this session and to invite our speakers also. Over to you, sir.
Thank you so much for your nice introduction. First and foremost, I want to give you the compliments to Dr. Bansi Sabu. Such a nice feast since last 2 days, and extraordinary attendance is there. Today is our first topic is acute and chronic complications of the diabetes. Are they preventable? And we are having very good speakers from Hong Kong, Dr. Juliana Chen. She is a professor and clinician scientist and graduation from the Liverpool. She is currently professor of the Medicine and Therapeutics Foundation and director, Diabetes and Obesity and Diabetes Clinic Research Management Office. Her major areas of the interest is including the epidemiology, genetic and clinical trial, and one of the principal investigator of the NIH founded Global Diabetes, and the Hong Kong government of the funded theme-based research involved in the diabetes. In 1997, her team received the Best Hong Kong Hospital Team Award. In 2007, her team set up the Asia Diabetes Foundation as a university. Over the years, she has organized many conferences, seminars, and workshops. She is currently a member of steering committee of the Hong Kong government and framework for the control and prevention of the uncommunicable diseases. We are definitely facing the COVID scenario, and since last so many years, we are also having the one chronic problem of pandemic, that is of the diabetes. So I'm now inviting you, madam, and please you continue your lecture.
Okay.
Thank you. Can I share my screen?
Can you read out poll?
Can I share my screen?
Yes.
Just a minute.
Yeah.
There is a. I'm just
Is diabetic neuropathy preventable or reversible? This is a question to for the poll.
Everyone can vote here.
Okay, am I in a position to start?
The result is a 50-50. So
Okay.
I think so the ball is in the speaker's court.
Okay, thank you.
Yeah, thank you.
What you, madam?
So can you hear me and can you see the screen?
Yes, please.
Yes.
Thank you. Okay, so let me just, okay. So first I would like to thank Dr. Sabu and also the organizing committee for inviting me to give this talk. Acute and chronic diabetes complications, are they preventable? So over the next 15 to 20 minutes, I'm giving a more kind of philosophical view regarding this topic, because I think we've learned a lot over the last 30 years. And personally, I think we have a lot of knowledge, a lot of tools, and also a lot of armamentarium. The question is how we're going to implement this. However, I think given the complexity of diabetes and its complications, maybe we either as practitioners or researchers, we need to take a broader view in order to create this impact. So I think we're living in a rapidly changing world with a considerable connectivity of education, health, and wealth. As a low and middle income countries moves towards a high income countries, there will be a lot of changes. particularly there will be more investment into education, into environment, reducing, a lot of social equity, and as a result, there will be a reduction in morbidity and mortality. The question is this transition happening fast enough? And within these natural transitions that we're all facing as a country or as an area go through this economic development, there are also other factors that we need to take into consideration. Particularly on a local basis, our ancestry, our geography, our cultures, and our genes would actually provide some kind of a framework, and upon which we interact with other factors, particularly in these modern days related to globalization and ecosystem. And I hope to actually frame my talk within this, background. We all know that diabetes is obviously causing a lot of morbidity and mortality. It is one of the 4 NCDs, but it is also the main NCD that actually causes the other NCDs. The presence of diabetes increases the risk of all-cause deaths, cancer deaths, CV death, and non-cancer, non-CV deaths, mainly related to renal disease and sepsis, anywhere between 80% to 3-fold. And therefore, preventing and control diabetes will actually give us a lot of impact on the other NCDs. And we now know actually diabetes is preventable. If you look at this survey, these are really more than 40,000 people who have been followed up since the age of 50 till the age of about 70s. So over the lifetime risk for diabetes is closely related to the number of healthy lifestyle factors. So if somebody never smokes, have an alcohol drink per day, have vigorous exercise twice a week, have healthy diets, and have good BMI, you could see that their lifetime risk of having diabetes is indeed very, very low as compared to somebody who have none of these healthy risk factors. So really highlighting the importance of having healthy lifestyle. However, to do this, that is easy said than done. It needs an environment, it needs support, and it needs education. However, we could see that actually in many parts of the world, particularly the high income areas where data are available, we are now seeing a decline in terms of diabetes incidence in some high income countries such as Canada, Israel, US, Portugal. And these reductions are quite substantial over the last 10 to 15 years, about 30%. Now, what the country has been doing is obviously the lessons for other countries to learn. But even within the same country where improvement is noted, that we are also seeing social disparity. And I think this is an important area that maybe we should be playing a bit more advocacy so that decision makers can actually create that environment. Using US as an example, one could see that actually, men have generally higher death rates if they have diabetes compared to women. But even within the same gender, you could see that actually people who have low income have nearly 2 times death rate compared to somebody who have low income. And also among the different ethnic groups, you could also see that the non-Hispanic white actually have higher death rates. And again, that interactions between the non-white population and also income put these people at very high risk for morbidity and mortality. If we talk about complications, obviously we cannot go without talking about type 1 diabetic ketoacidosis. Here, this is one of the largest review. Here you could see that actually the incidence of DKA really, spread all the way from 0 to here. This is in China, which is 263 per 1,000 patients year. And so with a lot of variability, even within the same country and during different time points. This data actually coming from Kadura Biobank that only came out about 5 years ago. And here, when you actually start measuring, then you could actually see that some countries actually have a lot of problem. In China, this high DKA rate is mainly seen in the rural areas as compared to the urban areas. But even within like USA, you could see that people who have a good glycemic control compared to somebody who have actually poor glycemic control, the risk of DKA is substantially, we're talking about 10 times difference. And importance about, emotional distress. So here in this particular survey, people who are depressed are also more likely to have DKA. So we have to look after both the physical and mental health in order to reduce these complications. In this survey, it was also, again, noted that people who have, again, in USA, where there are lots of data, that people, again, the Hispanic and also the Black populations, they have, again, higher incidence of DKA compared to the white population. And that the quality of care, such as using pumps versus people who are just using conventional delivery system pens, there is also 2 times difference in terms of DKA. So, although we have a lot of evidence from clinical trials, in real world practice, there's still considerable care gaps. The good thing is this variability tells us that if we put the right systems and policies and care and practice in place, we can make a difference. Here you could see the incidence of all the diabetes complications in terms of acute myocardial infarction, amputations, which related to the neuropathy and the PVD, the stroke and the end-stage renal disease to some extent has come down quite dramatically over between the year 1990 to 2010, with nearly 50% reduction in this incidence. And again, looking at some of these countries, such as even in Taiwan, UK, US, and Israel, you can again see the decline in terms of all-cause mortality in people with diabetes. So these data are encouraging, and that is, it is diabetes and its complications are largely preventable. If we look at the Swedish National Diabetes Register, again, very good databases. Looking at heart failure, we now know that actually heart failure is now one of the major unmet needs. Here you could see that the risk factors, A1C, the blood pressure, the lipid, the albuminuria, and smoking, these are the 5 risk factors which are again highly modifiable, for which we have a lot of evidence suggesting that reducing A1C by 1%, blood pressure by 5 to 10 millimeters mercury, as well as LDL cholesterol by 1 millimoles per liter, we can reduce the risk by at least 10 to 20%. And here again, within different age group, the more risk factors we have, the higher risk of heart failure. However, we now realize there's considerable care gaps, and that's actually, if you look at attainment of A1C alone, you could see that the rate can be as high, less than 7% as our target. In Sweden, nearly 80% on target, as compared in some of the lower middle countries, only 1 in 3. And when it comes to all 3 targets, then really in many countries, less than 10% of people can achieve all 3 targets. So we now have many, many drugs. We have now 9 drugs, 2 injectables. However, how do we actually give drugs, giving the right drug at the right time to the right people, really calls for a lot of assessment, because without that assessment, it is very difficult to make decisions. And you can see that what we are really trying to do is try to avoid this Nike sign and the slow deterioration of A1C silently. And then when the patients develop complications, we're trying to aggressively manage it. But what we are trying to do is really to manage them from the very outset and try to actually get them to go in order to avoid this burden, exposure to glycemia. And this, again, now a lot of data have shown that, for example, people even compared to people who have A1C less than 7%, and those people who have A1C more than 7%, that early, reduction in or that early exposure to high A1C over time will be translated to near 50% increased risk of myocardial infarction, stroke, heart failure, and also multiple cardiovascular events. So the important thing about diabetes is, of course, we have to measure, to manage, and monitor. There are many risk factors that we have managed, and most of them are actually people do not actually complain about it. If you don't measure it, you cannot make any decisions. And the combinations and permutations can really be infinite. And however, to actually do this, we cannot actually just do it single-handedly. So this is a meta-analysis showing that looking at nearly 180,000 people who are actually intervened using different quality improvement programs and looking at strategies targeted at the health system, at the healthcare providers, at the patients. And we could see consistency, team change, and facilitated patient relay, either using technology or non-medics to make sure the communications is good between the provider, the doctors, and the patients, as well as patient education, self-management, can actually reduce A1C by anywhere 0.5% to 0.8% on top of the usual care. And we see the same impact for other risk factors, blood pressure, LDL cholesterol, and this is particularly useful in those who are young, who've got poor control, and in low resource setting. So many of you probably know that in Hong Kong since '95, we have been using data, team-based strategy in order to actually understand more about the natural history of diabetes and also to measure the impact of various interventions. So from the Hong Kong Diabetes Register, we were able to link it periodically to the EMR and the death register, and then allow us to actually develop risk algorithms, and then using this risk algorithm to stratify risk and to actually visualize that risk and then communicate that risk to the individuals in order to reduce clinical inertia and non-adherence. With that, so I think with these data, we start to learn a lot more. So yesterday I talked about the COVID-19 and diabetes, and this is really not just about chronic complications, even infections. People know that diabetes have actually 2 to 3 times higher risk of having infections. And here in the register, we could see this near linear relationship between A1C and all infections, all sites infection, respiratory tract infection, genital urinary infection, and also skin infections. And when we actually look at different determinants, of course, age is a very important risk factor. Here you could see the older people are more susceptible. Past history is also very important. People already got organ damage in terms of heart failure, stroke, peripheral vascular disease, sensory neuropathy, or cancer, increase the risk of having infection. However, glycemic control is very important. So if we could actually improve the glycemic control, reduce the smoking, and also controlling the body weight, all these also have positive benefits in actually reducing the risk of infection. Along the way, the renal function, the blood hemoglobin, these are all partly related to disease durations and also the comorbidities of these individuals. So all people with diabetes are very different. Some people with diabetes, if they're well managed, they have no risk factors, no complications, good glycemic control, their risk of having infections may be just very similar to somebody who have no diabetes. But with more risk factors and more complications, the risk obviously is substantially increased. Having these registers are very powerful, I believe, because they are not only useful in terms of informing practice, but they also inform the policies. And I think after these 15 years of healthcare reform in Hong Kong, we could see the declining rate of diabetes related deaths in our populations. So between 2000 and 2016, we now have a very big database in Hong Kong capturing the information of 0.8 million people, and we could see a substantial decline in terms of the deaths and also complications in people with diabetes, showing that indeed these complications and death can be preventable. But what's worrying is that actually among the young people, we are not seeing the improvement. Here, this is a standardized mortality ratio, which is still about 5 to 8 times higher among the young people compared to their peers without diabetes, whereas actually among the elderly, the risk is now becoming quite similar to the young, to the non-diabetic peers. What's even worrying is also we are now seeing an increasing trend of diabetes among the young people. So this is again using the register. We could see that actually we are actually managing quite well, improving a lot of the disease patterns and outcome in the middle age, but not in those young people less than 20 and between 20 and 40. We continue to see a rising incidence of diabetes in these individuals and clearly calling for more efforts. And this is really looking at the young onset diabetes, and you could see because of the long disease duration, these people are likely to have a lot of hospitalization over their lifetime. And on average, a person with diagnosed at the age of 30, for example, might spend more than 100 days in hospital during their lifetime. And these are related to either cardiovascular disease, infections, hypoglycemia, or renal disease. But what's more concerning is actually during the early years of diabetes, mental illness is actually very important. Here you could see that actually compared to the late onset diabetes counterparts, these people with young onset diabetes actually have about 2 to 6-fold increased risk of infection, cardiovascular disease, renal disease, and also hyper or hypoglycemia. And we modeled that actually if we can intensively manage these individuals, so if somebody had diabetes at the age of 33, they may spend 97 days in the hospital during their lifetime. If we can intensively manage all their risk factors, including quitting smoking and normalize all risk factors, we can reduce it by about 30%. But it is really by delaying the onset of diabetes to the age of 50 or even 60, can we truly reduce the impact of diabetes in these young individuals. And that brings back the point that maybe the life course of diabetes is important. We now know that actually 1 in 6 live births, 20 million live births are actually affected by hyperglycemia during pregnancy. And these 84% of these actually gestational diabetes. And in this HARPO study, we followed these 917 mother and the offspring after 7 years. We found that actually the children born to mother with abnormal glucose tolerance, their risk of having abnormal glucose tolerance, even at such a young age of 7 years, was 4.7%, compared to 1.7% in those children whose mother did not have gestational diabetes. And of course, this is accompanied by a higher risk of a lot of the cardiometabolic risk factors, including obesity, blood pressure, and also poor beta cell function and insulin resistance. So ladies and gentlemen, I would like to really conclude that I think after 30 years, there is a lot of data, clinical experimental data suggesting diabetes indeed preventable. We all have a slightly different genetic makeup, and the best scenario is if you have low genetic risk, you have good lifestyle, you have early intervention, we have healthy aging. There are people who have not so good genetic risk, but if this is coupled with insufficient nurturing, unhealthy lifestyle, delayed intervention, these people might have problems in the middle age. But between these two extremes, there is really considerable opportunities for us to prevent and also to treat early in order to change the trajectory. And I think this would actually rely on concerted effort, not just the practitioners, but also the researchers and also the policymakers and the payers. And thank you very much for listening. Hello? Sorry, I'm not sure whether you could, you're muted.